Hello everyone, my name is Lauren Alter and I'm starting out our group presentation on reducing delirium in elderly patients in a hospital setting. I'd like to start out the presentation by first defining delirium and start out by saying that it's a syndrome. So basically that means it's a group of symptoms, and some of the characteristics of it are acute confusion. That's different from dementia in that dementia is a chronic confusion. Delirium is characterized by inattention, disordered thinking, altered mentation, and it tends to develop over hours or days in comparison to dementia, which would be months to years. A patient with delirium can experience perceptual disturbances, so they may have hallucinations, they may feel like they're in some type of a dreamlike state, and delirium is always in response to some other medical condition, and there are a host of them that can contribute to delirium, which we'll go over later. And some other things that sort of differentiate delirium from dementia, which I think is important to note because dementia has some of the same overlapping characteristics. But delirium patients, their attention is significantly impaired. And with dementia, usually these patients that have it stay alert all the way up until the later stages of dementia. For delirium, you have more fluctuations in mentation throughout a given day, whereas in dementia, memory and thinking stays fairly constant during a regular day for them. And for delirium, it is something that can be potentially reversed and can last for maybe months at the most. But dementia is irreversible. It lasts up until the end of a person's life. So the next slide here goes over the three different types of delirium. The hypoactive form of delirium is more common than the hyperactive type. It tends to mimic a coma or stupor. These patients are very lethargic and have a severe form of inattention or somnolence. And this type is not as easily noticed because it doesn't grab everyone's attention. So therefore, sometimes it goes a little bit, it tends to be less treated because, the patient's not causing a lot of commotion or anything like that. The hyperactive form of delirium is where a patient is agitated, confused in this. They may have perceptual disturbances, restlessness, and combativeness. And this is very easy to notice, this type, because it gets a lot more attention. A lot of these patients may be physically combative and try to escape the room, get out of their beds, pull at their lines, that sort of thing. And then you have the mixed type of delirium, which has features of both. It is definitely the most common. And a good example of this would be if you had a patient who was very lethargic throughout the day, and then when the evening hours come, they are unable to sleep and extremely agitated at that time. Something similar to, say, maybe sundowning. So one of the reasons why we chose delirium as our topic is because as a group we all came to the conclusion that we've had exposure to patients experiencing delirium someplace in our work history as nurses. And not only that, but delirium is such a significant problem for the population that we're studying, for those elderly who are being admitted into hospitals. And it's associated with morbidity and mortality and long-term functional and cognitive decline, falls. A couple things that I just mentioned right there are already issues with the elderly. It's associated with longer hospital stays and there's a high rate of deaths for patients that experience delirium just months after the incident. And I actually have personal experience with this, as my grandmother experienced a hyperactive form of delirium, and while she was in the hospital, that lasted for a couple of hours, and a couple months after that, she passed away. So I definitely understand that statistic to be true, or at least in my experience. Delirium is also associated with increased costs, which is always a problem in healthcare, and increased use of restraints, and it's an independent predictor of death in the elderly. So we felt it was very relevant. And then I just want to present a couple of statistics from the Foundation of Health and Aging, just to give you an idea of its prevalence in the elderly. So 1/3 of the elderly that arrive in emergency rooms apparently experience delirium, and 1/3 of patients over 70 that are admitted to the hospital experience it, as well as 2/3 of the elderly experience delirium after a major surgery.
Nurses' awareness and recognition of delirium is vital in reducing delirium in elderly patients in a hospital setting. In order to implement interventions or treatments, nurses need to first realize the significance of elderly delirium and effectively recognize the signs and symptoms of delirium among those elderly patients. According to a study conducted by Zeeland, Sandhaus, Kowalewski, wrote prior on the hospitalized older adults with established delirium, the key of improved patient outcome lies in timely, accurate, and effective recognition, documentation, and reporting. In their study, the performance of nurses and physicians in recognizing, documenting, and treating delirium is inadequate, despite the adverse consequences associated with delirium. This inadequate recognition and documentation of delirium is caused by superimposition of other comorbidities, organizational factors, and inconsistent documentation. Delirium is usually superimposed on dementia, increased patient acuity, deficits in hearing and vision, and the fluctuating symptoms of the delirium itself. Organizational factors such as a lack of time and staffing further impact efforts to improve recognition and documentation of delirium. And the most common cause of this inadequate awareness and recognition of delirium is that the documentation of delirium remains inconsistent. Because healthcare professionals use a variety of descriptors to document and communicate their delirium assessments, important information necessary to provide delirium prevention and treatment may not be conveyed. Zeeland and colleagues have determined the most common descriptors used for delirium in documentation and interdisciplinary communication. And these descriptors include confusion, mental status change, disorientation, lethargy, agitation, and poor historian. Due to the successful and prevalent adoption of electronic health record or EHR, it is helpful to use various tools assisting nurses and doctors in early recognition of delirium in elderly patients. Zeeland and colleagues have recommended natural language processing or NLP and clinical decision support or CDS. Natural language processing can analyze coded and free text portions of EHR, and the clinical decision support can identify delirium and delirium superimposed on other comorbidities. By adopting these tools, nurses can have better awareness and early recognition of elderly delirium in hospital settings to greatly improve patient outcomes.
I'm going to talk about non-pharmacological interventions for delirium. A multidisciplinary team works well to help prevent delirium by having a good team involvement of nurses, therapists, including social worker as well, and using the same hospitalist group works well too. They're able to see a quicker change in status if that was to happen versus if the patient had different doctors during their stay. Also, that's the same thing works well with the same nurse, also highly trained in delirium. Using the same nurse works well because they are able to see a change in status quicker also. Um, there is something called the Hospital Elder Life Program, also called HELP, which is an evidence-based patient program that will try to keep the patients oriented to their environment and also helps meet the needs of their nutrition, sleep, and mobility. Also, a few non-pharmacological interventions is using a medical software at the hospital that uses checklists. It's something that the nurses can use to do routine geriatric care, frequent delirium screening assessments. Also, the early mobilization program works well for preventing delirium. It helps get the patients out of bed. Getting them out of bed also helps with cognition, also helps with brain activity. Also, having a familiar face in the hospital, usually patients work well with that. Where I work at now, we try to ask the family or friends to stay with the patient if they can in the hospital. They usually respond well to that. Now I'm going to talk about pharmacological interventions. Just a side note here that there is no drug on the market that has been approved solely for the treatment of delirium. So symptom management is the answer at this point when medicines do have to be used. Antipsychotics is one group that has been used per the evidence. Ketamine, which is also called, ketapine, also called Seroquel, helps decrease agitation, has had a greater outcome versus some of the other psychotics listed there. Also, it was stated that Haldol works well, but only used in short term. Also, benzodiazepines are used for delirium. The benefit of that is they do have a more rapid onset of action, so you may get a quicker response versus in some of the other medications like the antipsychotics. Opioids can be used as well. The benefit of that is you can treat pain and delirium. Also, CNS stimulants such as Quilivant, which is used in ADHD treatment, has increased alert and cognition for these patients that are suffering from delirium.
Acute interventions for delirium. There are many different types of delirium. It can be acute or chronic. Interventions and treatment for delirium will depend on the reason. The healthcare team will screen for reversible causes. To name a few is hypoglycemia, hypoxia, dehydration, infection, and excessive opioid use. Delirium from dehydration interventions. Prevention is the most important treatment for delirium. Educate the patients and prevent them from becoming dehydrated. It's important to educate older adults on dehydration risk. Make fluids easily accessible. Serve fluids at a temperature the individual prefers. Encourage water with all meals. Boost the flavor with adding lemon drops or lime juice, whatever they prefer. If unable to drink, then treat with intravenous fluids. Delirium from infection interventions. If you suspect an infection, the doctor is likely going to order some blood work. This includes CBC, look at the white blood cells, blood cultures, urinalysis, urine culture, possibly lactic acid. Treatment would be antibiotics. Be sure to give antibiotics, be sure to draw blood cultures before giving antibiotics, fluid therapy, chest x-ray to look for possible pneumonia or bronchitis, anything that may cause an infection, or lumbar puncture if you suspect meningitis. Delirium from polypharmacy interventions. Drugs are one of the most common risk factors for delirium and may be considered the most easily reversible trigger. Review medications for any recent changes or increases in dosages. Encourage the patient or family to stop or taper the medications to help treat delirium. Be mindful if the patient has any impaired renal function. Many medications clear through the liver or the kidneys, and if they are impaired in those areas, they can build up an increased amount of the medication in their system. The patient may need antidotes such as Narcan or Romazicon to help reverse the effects of opiates or benzos. Delirium from hypoxia or hypoglycemia interventions. If you suspect the patient is confused because of a low blood sugar, quickly get an AccuCheck. If the blood sugar is determined to be low and the patient is alert enough, you can give them something to eat or drink or some glucose tablets. If they are unconscious or unable to chew and swallow safely, you can give them IV glucose as ordered by the physician. If the patient is hypoxic, the healthcare team needs to determine the cause. First step will be to apply oxygen to get the SATs greater than 93%. Hopefully that will improve the mental status. Lab tests needs to be done to include blood gas analysis. Will help determine if the patient is retaining CO2. Depending on how out of normal the arterial blood gas is, will help determine if the patient needs BiPAP or intubation. Serial observation of arterial blood gas and patient condition will help guide their care.
There are many risk factors that are associated with increased risk of delirium. According to our text, delirium is rarely caused by a single factor. In fact, Dr. Gerontology and colleagues call it an intrinsically multifactorial syndrome. In a 1999 article in the New England Journal of Medicine, Dr. Inouye and colleagues showed that the risk of delirium increases with the number of risk factors present. They further found that reducing the number of risk factors contributed to the effectiveness of an intervention strategy. Dr. Margaret Zalon and colleagues have suggested that due to the large number of risk factors, instead of trying to identify everybody who has one or more risk factors, we should focus on individuals who are at the highest risk. So what are these risk factors? We're glad you asked. Our textbook divides risk factors into two groups: predisposing factors and predisposing triggers. Predisposing factors are baseline vulnerabilities that the patient has prior to hospitalization. This list is aggregated from our text, as well as the Hartford Institute for Geriatric Nursing. Factors include advanced cancer, alcoholism, cognitive impairment, certain medications or polypharmacy, chronic pain, dehydration, fluid and electrolyte imbalances, hypoxia, impaired cardiac or respiratory function, infection, which is usually urinary tract or pneumonia, malnutrition, medical comorbidities, a medical history of delirium, metabolic disturbances, a pre-existing dementia, sensory impairment, vision or hearing loss, or just unfamiliar surroundings. Conversely, precipitating triggers are events or conditions that can occur during hospitalization to cause an acute exacerbation of delirium. Examples of triggers from our text and the Hartford Institute for Geriatric Nursing include absence of a clock or watch, absence of reading glasses or hearing aid, acute cardiac or pulmonary events, bed rest or immobility, drug withdrawal, fecal impaction, fluid or electrolyte disturbances, increased number of room changes, indwelling devices such as urinary catheters, medications, hospital-acquired infections, restraints, severe anemia, sleep deprivation, uncontrolled pain, or urinary retention.
Delirium is a syndrome that frequently affects the elderly population and causes acute confusion, disordered thinking, inattention, perceptual disturbances, and altered mentation. Delirium develops over hours or days and may be in response to medical conditions. Reducing delirium in elderly patients in a hospital setting is important because delirium has been associated with several negative outcomes such as longer hospital stays, increased costs, falls, long-term functional and cognitive decline, increased use of restraints, and an increase in morbidity and mortality. The first step nurses can take in reducing delirium in older adults is being able to recognize delirium by using tools such as natural language processing, NLP, and clinical decision support, CDS. When an elderly patient has delirium, non-pharmacological interventions can be used to help manage the delirium, such as daily patient rounding, checklists, early mobilization programs, having familiar faces around the patient, and restraints, which should always be used as a last resort. In addition to non-pharmacological interventions, pharmacological interventions may also be used for symptom management, such as antipsychotic medications, benzodiazepines, opioids, and CNS stimulants. Delirium may be a result of underlying medical conditions, such as hypoglycemia, hypoxia, dehydration, infection, chronic pain, alcoholism, malnutrition, sensory impairment, polypharmacy, and excessive opioid use. Other precipitating factors that can cause delirium in the elderly are absence of a clock or watch, reading glasses, or hearing aids, excessive bed rest due to immobility, drug withdrawal, fecal impaction, indwelling devices such as urinary catheters, restraints, sleep deprivation, uncontrolled pain, and urinary retention. Therefore, an important way to reduce delirium in elderly patients is by identifying and treating the reversible causes. Studies have shown that 1/3 of the elderly population that presents to the emergency department are experiencing delirium. Also, the risk of developing delirium increases with age. Due to the high prevalence of delirium in elderly patients and the growth of the older population, it is imperative that nurses and other members of the healthcare team are able to understand, recognize, and manage delirium in the elderly. Through the implementation of non-pharmacological and pharmacological interventions, treating underlying causes, and patient teaching, the rate of delirium seen in hospitalized elderly patients can be reduced, leading to the reduction in negative outcomes and ultimately improving the quality of life in older adults.